had it. Large breed dogs, small breed dogs, and cats. So just remember one or the other. And then they're born idiopathic, congenitally small livers. Deep-chested animals tend to have small livers. Appearance, but it's only because they're deep-chested and the liver diaphragm has moved cranially. Okay, normal location of the liver and spleen. The tail of the spleen is readily visualized in the dog. If you see the tail of the spleen in the cat, you consider that abnormal until otherwise. The caudal margin of the liver and the tail of the spleen commonly associated with each other lateral, on a lateral view. And that is why we do right side down for the abdomen. When we do right side down for the abdomen, it displaces the tail of the spleen caudally, so you can see the separation between the liver and the tail of the spleen, right side down. Left side down, sometimes the tail of the spleen will move cranially, and you see it right up against the caudal margin of the liver. And sometimes it's difficult to tell if you're looking at the tail of the spleen adjacent to the liver, or are you looking at all liver? And then you don't want to misdiagnose that as hepatomegaly. I want to note on the ventral dorsal view, where the orange arrow is, there's a soft tissue opacity overlying the spine. Not to be confused with urinary bladder, that is the prepuce. So extra-abdominal structures, prepuce, masses, teats, ticks, down in the south, big huge ticks can look like, actually I had a case when I took my radiology board, it was a tick. I knew it wasn't intra-abdominal. You know why? Because it was soft tissue. It was more opaque. So I knew it was an extra-abdominal structure or something on top of the abdomen. So extra-abdominal structures tend to be more opaque because they're external and then there's air around them. So the X-ray beam sees that structure superimposed on the other abdominal structure. If the structure was intra-abdominally, you would not see it because it blends in with the rest of the soft tissue. Everybody understand that? So is the prepuce commonly said bladder? Yes. But you notice the bladder should not be that opaque if it's intra-abdominally unless it's calcified. Now you can say calcification in the bladder, I'll take that. But just remember the prepuce, any extra-abdominal structures, same thing with thorax, cause opacity. So generalized versus localized splenomegaly. You know where the tail of the spleen lives. So then instead of having the nice sharp margins, triangular shaped margins of the spleen, the head of the spleen is located here, sharp margin, upper left quadrant. And so there's a triad there. The fundus of the stomach, the head of the spleen, and the left kidney. So that's a triad. So if you can find one, you can typically use that triad to find the other two structures. So if there's splenomegaly, if you're looking at a ventral dorsal view, you're going to look in the upper left quadrant. Well, when the head of the spleen becomes enlarged, what happens to the stomach? It goes medial. What happens to the left kidney? It goes caudally, or sometimes it can go medial. So it's just all about where it's located. When it enlarges, what structures are being displaced. On the lateral view, you lose this triangular shape. The tail of the spleen may become elongated, or it may have rounded margins. Well, if the spleen is large and swollen, it would have rounded margins. So this is what it would look like. A mass effect could be the same So you would look for a soft tissue opacity wherever the spleen is located. Okay, question.
For the triad, you said it was the head of the spleen, the left kidney.
The fundus of the stomach, head of the spleen, and left kidney.
Thank you.
That's the triad in the upper left. Because if you just, sometimes when you look at ventral dorsal views, you don't know where structures are. You have to find, your eyes have to adjust to those layers. If you know where one structure is, you know you have to look medial or lateral to find the other structure in conjunction or connection with each other. Examples of splenomegaly. Now this is, the image, this one is a cat. How do you know? Okay, the shape of the lumbar vertebrae. And this is the tail of the spleen, so you know that's splenomegaly in the cat. And the liver is also enlarged. So hepatomegaly, splenomegaly. And then this is a dog. Sometimes the margins can be irregular. So you look for all of those radiographic findings to determine that it's splenomegaly. So radiographically, your diagnosis would be splenomegaly. That's your diagnosis, radiographic diagnosis. And then you know what I'm going to ask next. Well, what do you think is causing the splenomegaly? Then that's where you come in. You have to have 3 differentials right off the bat, if you can. Okay, so then on the ventral dorsal view, you start at the head of the spleen, and if you see the spleen along the left side of the abdomen, it could be a sign of splenomegaly, or the spleen could be just normally located there. You go back and look at your lateral view and see if you see the evidence of splenomegaly on that view. For mass effect, you look for soft tissue opacity, and when we talk about masses, we'll talk about that in a minute. We talk about where it's located and what structures the mass may be displacing and what the mass may be originating from. So where the black arrow is, everybody can see that there's a soft tissue opacity kind of indistinct. You don't see it distinct, you see it indistinct, but you see a soft tissue opacity superimposed on the fecal material within the colon. And the head of the spleen is more widened or elongated. Here's your long list of differentials for spleen. The very first one you need to determine is the pet under anesthesia, or there's some use of barbiturate. That's the most common cause of splenomegaly. And then whatever these are the rest of the differentials. For the liver, a common cause of hepatomegaly in dogs is steroid administration. If the pet is on steroids for a long period of time, that's a common cause of hepatomegaly. So you make sure you ask that question when the pet comes to your practice. So let's talk about masses. Masses. When you look at the abdomen, when you look at images, and you see a soft tissue opacity, and you say, gosh, I don't know what that is, I don't know where it's coming from. But if you use these 4 parameters, it helps you hone in on what you think might be going on. So 1, what density is it? If it's soft tissue opacity, is it radiolucent? If it's radiolucent, you'd not be thinking some type of fatty mass. Soft tissue, radiopacity, that could be anything. Then second, where is it located? Where is it located? Because you have to think about what structures are located where the mass is associated with. What structures is the mass displacing? And then you talk about a differential for whatever structure is located in that area. Because you're not going to see pancreas. You're not going to see ovaries. You're not going to see mesenteric root. But if the soft tissue opacity is originated from there, every structure is located there, you will put in a differential. Make sense? Oh, I hate that. Do you understand that? Got that? Yes. Okay, great. Okay, mass effect. Go back to that, to the one. What is that? I'm sorry. No, this would be, now we're talking intra-abdominal. Okay, see this one, you see this soft tissue opacity, you can just barely see it? Look at this one. That one's pretty bright. So, masses are still soft tissue, they're just large. They're not, if they're more opaque than normal soft tissues, it has a mineral in it, right? Because you move to the next category. Fat, soft tissue, mineralization, gas, and mineral. Okay, good. So let's go through a few. If you look at this image, you go, okay, that doesn't look right. But let's start recognizing what you do see. First of all, cranial dorsal, you see gas. Well, what's located cranial dorsal? Fundus of the stomach. So there's gas in the fundus of the stomach. Ventral to that, you see a soft tissue opacity. So what would you say first? There's a soft tissue opacity, or there is a radial opacity. Where is it located? Cranial ventral abdomen. What is it displacing? Small intestine or intestinal loop. Now, what could it be originating from? What all lives there? Liver is going to be your number one, because that's where the liver lives. What else lives there? Pancreas, stomach. Now, why not spleen? Because the spleen does not displace the stomach and bowel loops caudal. The spleen is located caudal to the stomach. So you would not put spleen in your differential here because the spleen doesn't live there. The spleen lives caudal to the stomach. Okay, so this is one where it's a soft tissue opacity located mid-ventral abdomen, displacing the stomach cranially, small intestine dorsally, intestine caudally. Then you would talk about, well, what lives here? Well, your first organ is going to be spleen. What's next? What else lives there? Kidneys tend to cause the bowel loops to displace ventrally. Now, you can put kidney, but I want to hear something else other than kidney first. What lives in the mid-abdomen other than spleen? Intestine, mesentery, lymph nodes. Okay, so that's how you approach masses. Now you talk about the opacity, where they're located, what they're displacing, and then what it could be originated from. Okay, cranial dorsal mass effect. You don't really see the mass itself. All you see is a soft tissue opacity, correct? So without any history, you have to do the same thing. There's a soft tissue opacity in the cranial dorsal abdomen. It is adjacent to the caudal margin of the stomach. Is it adjacent to the caudal margin of the stomach? Is it displacing the bowel loops ventrally? Okay, great. What's located there? The head of the spleen is there. Now you can say kidneys. What adrenals, ovaries, fundus of the stomach, because it could be a mass originated from the fundus of the stomach. Pancreas, let the pancreas swing up that way, as well as the omentum. Lymph nodes, etc. Throw in lymph nodes every time there's a mass. Because they're everywhere. It's okay, that's okay. But you wouldn't list them first. You think about organs first, and then put in the lymph nodes. Okay, this happens to be a mass from the head of the spleen. Okay, loss of serosal detail. Loss of serosal detail. All it means is that you're not seeing the outlines of the intestine, or you're not seeing the outline of organs. So whatever that might be. If you say there's what my differential is fluid in the abdomen, then you know there's all types of fluids. And so we talk about peritoneal effusion. So your radiographic diagnosis is going to be peritoneal effusion, because you don't know what kind of fluid is in the abdomen until you do what? Abdominal centesis. Okay, abdominal centesis, yes. Then you determine if it's blood. Now you got to still do another differential. If it's a transudate, then you do another differential. So every time you say something, you get, oh my gosh, what causes that? That's why? What? Peritonitis, diffuse metastatic disease. Well, if the animal is emaciated, that's a cause because it's lack of fat. So then it's some more soft tissue. And of course, brown fat in young animals. Brown fat is more like soft tissue. So then you do not see the detailed margins. So these are some examples. I think you can picture that all of these have loss of serotonin. You don't see the abdominal detail as well. And so that would be your radiographic finding, and then you would tell me what you think is going on. I think that there's generalized peritoneal effusion. That's your radiographic diagnosis. And then you be specific with your differentials. The reason why this one is emaciated, you look along the dorsum. And remember, you're going to go through extra abdominal findings first. So there's loss of fat along the dorsum, and look how tucked up appearance this lateral view is. So this is one where not only has this intra-abdominal mass of fat, it is also emaciated. Well, neoplasia does kind of cause that, doesn't it? Pneumoperitoneum, air in the abdomen. Anytime you see air in the abdomen, surgery you go. You don't even have to determine where the air is coming from. Just go in because it is a surgical emergency. The gas is coming from the GI tract. There's a rupture in the GI tract. What do we look for radiographic findings? Air tend to loculate between the liver and the stomach. That's where gas peaks. Now, it could be anywhere in the abdomen, but I want you to look there first. I want you to look where because it's moving in the abdomen. Rest, inspiration, expiration. So the gas is moving cranially. Well, it's not going to go past the diaphragm because the diaphragm is intact. So look at this area and see if you see a small pocket of gas. You all see it? Now, it's a little bit more lucid than the air in the fundus of the stomach. And if you look at the diaphragm adjacent to it, it's a little bit more lucid than this adjacent air. That helps you identify it. All of y'all should be seeing that. Everybody see it? Can I move on? Okay. Look on the lateral view. So you see where there's a pocket of gas right at the margin of the liver and the stomach. Okay, so that your diagnosis would be a pneumoperitoneum. Now you can talk about the causes of it. I mean, the pet could have had a previous laparotomy, could have come to you from another practice. You have to ask that question. Yes, it had surgery. I'm traveling, and now it's ate a foreign body, etc., etc. I'm on my way home. It could have that kind of history. So you want to ask, did they have surgery before? Because you want to rule out that as a cause of the air in the abdomen. Other than that, it's a surgical emergency. Gastric dilatation versus GDP. Gastric dilatation, you know already the stomach is in its normal position. It's just distended. This is a gastric dilatation. GDB, it has twisted 180 degrees. So now, look how the pylorus is moving clockwise along this axis. So it moves ventral and to the right. So what does that look like on an image? Okay, thank you. So the pyloric antrum is on the left side, and the fundus is on the right side. Now that's easy to say, and it's easy to see that on this image. But when PEPs, great name, is presented on emergency duty, sometimes it's difficult to tell if it's gastric dilatation versus GDP. So what else do we look for? We look for this compartmentalization, which means that when it is moved, there is a segmentation of the stomach. And so then you see this ridge, it's a soft tissue ridge between the fundus and the pylorus. And this is what it looks like. The largest part, if it reads the book, you'll get it every time. But not all the time do they read the book. But look at this image. The largest part of the stomach is what? The fundus. The largest part of the stomach is the fundus. So on this image, where's the largest part? Ventrally. So should the fundus be located there? No. So that's the GDB, just that radiographic finding. And then the pyloric antrum has moved craniodorsal, and then this ridge is the compartmentalization. But look at the small intestine. They are distended as well. Well, when the stomach twists, there's going to be some paralytic ileus, there's going to be some pain. And so the small intestines are responding to that question.
So a lot of the readings say that it looks like a bookshelf. Is that bookshelf
Oh,
appearance?
bookshelf. I don't know what it's, I don't know what it is.
Yeah, so I'm trying to understand it. So the
A bookshelf?
yeah.
Okay, can you just show me where you found that?
Well, that's what I was mainly
Just
asking.
show